Next on primary care, more black children are being diagnosed with diabetes.
I'm actually seeing type 2 diabetes in younger children, even younger than 13 years of age. And it's because we're seeing this explosion of obesity.
Hello, and welcome to Primary Care, the show dedicated to improving the health and care of African Americans. I'm your host, Dr. Lonnie Joe. Diabetes is no longer just an adult disease. More African American children are being diagnosed with both type 1 and 2 diabetes at younger ages. In fact, type 2 diabetes in black youth often peaks around age 13. Over 90% of African American children with type 2 diabetes are overweight or obese. This is bigger than just weight. It's about access to healthy foods, safe spaces to exercise, consistent health care, and stress many families carry. When diabetes isn't managed well, high blood sugar can quietly damage the heart, the kidneys, the eyes, and even the nerves. Even in childhood, we see these diseases. Today, we're joined by Dr. Colleen Buggs-Saxton, a board-certified pediatric endocrinologist and associate professor at Wayne State University School of Medicine. She's here to help us understand what families need to know and what steps can make a real difference. Colleen, welcome to the show. So glad you joined us.
Thank you, thank you.
Good. Tell us what is happening to a child's body when they develop diabetes?
So, as you said, the rates of obesity is increasing, and we're seeing this in childhood. And so as a child gains more weight, the body naturally will make more insulin to try to keep the blood sugars controlled or in the normal range. And more weight gain causes more attack on the body, and those cells that make insulin get tired and stop making insulin over time. And that's when you end up with needing insulin or other medications to help control the blood sugar.
So we're seeing diabetes as young as age 13. I would have thought that it would have been a diagnosis more in the middle teen years or late teen years, but you know, that seems to be quite early and certainly a shift in terms of what we've experienced in the past.
Yes, I'm actually seeing type 2 diabetes in younger children, even younger than 13 years of age. And it's because we're seeing this explosion of obesity, and it's really impacting the body very early on in that child's life, contributing to not just diabetes, but other chronic problems, yes.
Mm-hmm. Are black children particularly vulnerable for this disease?
Absolutely. With the challenges or factors that contribute to weight gain, we know that these children have more access to unhealthy foods. We can start with what they drink, sugary beverages, processed foods, and there's no control over the amount. They don't have any clear guidance as to what is a normal amount of food or portions that they should eat. So they have access to these foods very early on. And so the whole process that contributes to type 2 diabetes, it starts very early. So it's not surprising that we're seeing younger and younger age children develop type 2 diabetes.
So it's not just the type or the food choices that they make, it's also an amount of caloric intake.
Absolutely, absolutely. In fact, I have parents tell me all the time, my child doesn't eat a lot of food. The problem is the foods that they're eating, there's so many calories packed into what appears to be a small amount of food, so it doesn't take a large amount of that unhealthy food to cause an excessive amount of weight gain.
So as an internist, we're used to dealing with, you know, the adult aspect of this disease state. What should children or what should parents be looking for in terms of signs and symptoms of diabetes in the younger population?
So the typical signs of diabetes can occur in both type 1 and type 2. So drinking or wanting to drink a lot of beverages or water, so very thirsty, urinating more frequently, especially at night, you may not pay attention to your child going to the bathroom frequently during the day, but if they're not sleeping and constantly getting up at night to go to the bathroom, if you notice that they're starting to have bedwetting accidents, that's another sign that your child may be developing diabetes. And then finally, if they just have unexplained weight loss, they just eat a lot, but they still lose a lot of weight, and you put everything together with increased thirst, urination, you have to consider the possibility that your child may be developing diabetes.
So how should we be screening the pediatric population for this disease?
So it's recommended that we should start at least at age 10, but also when there are signs of puberty. We know that puberty is a time period with hormones that are changing, and so there's a significant stress on the body. We know insulin resistance increases during puberty, so at least by age 10, but maybe even sooner if you have a child that started that pubertal process early.
So here we are being challenged in all aspects of care for patients of all ages. It's particularly sensitive to us when children don't have adequate food intake, don't have proper diets, don't have the ability to have access to health care on a regular basis, in particular something like screening. How are we doing in terms of improving on the numbers? Because for the most part, we kind of grown to the point we expect them to be poor. How are we doing in terms of screening, managing the pediatric diabetic?
So screening, I will say the pediatricians in the Detroit area are doing an excellent job with picking up these children early. So they are getting them into the primary care appointments and identifying those children who are at risk. And there is still a lack of subspecialists like endocrinologists so that these patients or parents can then get to the subspecialist to get like the treatment for diabetes. So that is still a problem, but we're still trying to do a better job, about awareness about type 1 diabetes and really getting kids to the specialists that they need.
So we from a cultural standpoint of view, there are a lot of beliefs around in terms of, what we do, what we eat, traditions have shaped a lot of what our intake is, and even in terms of what is carried in supermarkets and stuff, they can be directed to a ethical point of view in terms of choices that people make. What kind of struggles do you face in the African American community with people making those kinds of choices?
I think when people meet me, they feel very comfortable having an open, honest conversation. Dr. Buggs, I like to cook. I like to cook good food, and I like my seasoning. And so I try to respect, the importance of culture when it comes around food. But I also try to educate families, the harm if we overdo it, right? So I recognize when families, we have gatherings, we cook, we like certain food. So when you want to have your macaroni and cheese, you don't want to make substitutions. You don't want to make substitutions when you cook your greens, right? So enjoy those special holidays, but you cannot continue to eat like that on a regular basis every day and not expect for there to be health consequences.
Right. This
is
grandma's recipe, so we continue it. And, that's very common. Not to mention the environment that we see in neighborhoods. We used to refer to these places as food deserts, but they weren't food deserts. They just contained the wrong kinds of food, and people made the wrong choices, especially children. What is a child supposed to do walking home from school on a hot day when they can get a 2 liter for 99 cents on sale as opposed to a bottle of water for $1.29?
Absolutely. Yeah, it's very challenging. It really boils down to economics, right? What can you afford? But on the flip side, I've also had the conversation with families about what you're spending your money on and how that adds up over time. And what could you do with that money? Yeah. I had one family who stopped using DoorDash, and they saved enough money to have a wonderful vacation. So, there are some choices, and you do have to bring the non-medical components of obesity or type 2 diabetes into the conversation.
Yeah, we're truly creatures of habit in a lot of things in life, in our choices and what we eat, and even how we prepare foods. We kind of do it the same way. We don't experiment a lot. I find it very interesting for people who are able to bring out the flavors in food using spices and different types of pepper and stuff. How much of a dietary approach do you take in the pediatric age group for diabetes? We've been talking about diabetic diets, ADA recommended 1,800 calorie in adults all along. How does this apply to the peds age group population?
I think this is a very important component to the educational piece for diabetes, for obesity. So I actually have tools that I use in my clinic. So I actually took like a bottle of soda, or what is considered a healthier option for beverage, and I filled it with the amount of sugar that is actually contained in that beverage. So I pull it out in the bottle and I show the patient, the parent, when you drink this, this is how much sugar you're drinking. I do the same for cereal, even cereals that we think are healthy options. This is how much sugar is in what you're giving your child. And then there was this one situation where I had a family in clinic. The child was eating a snack and it was 11 o'clock, and I asked them, did they have breakfast? Yes, they had a morning snack, and now you're in clinic. And so I said, they really don't need this, and they left a wrapper in the room, and I cleaned it, and I looked to see how much sugar it was several teaspoons of sugar. So I used this information along with other processed foods like noodles, right? I actually have a package of noodles, and I give it to the patient, and it's not just about calories or sugar. I have them look at the ingredients, and I say, read it. What is that? That's what you're putting in your body. I don't know what it is. It could be a chemical. I don't know how it's going to interact with your body, but really just to make it practical, to get them to think before they put something in their mouth and realize down the road the damage that it could do.
I'm always reminding adults about reading labels. Children can do it also just as good as adults once you get them into the habit of doing it. But here again, I mean, since 1955, we tripled the content of sugar in average everyday things. This came along with before we were born, of course, but this came along with the craze of having cereal for breakfast and all those kinds of things. And if you look at the content and learn to recognize sugar by its various different names, we've seen ingredients that will have 8, 9, 10 different ways to say sugar listed on the package, and people not realizing that this excess sugar is basically our problem in terms of dietary control, particularly in a diabetic. So you're teaching them all to read labels.
Yes. I'm also teaching them to be strategic when they're shopping for food. So I point out that in a typical grocery store, the real food is in the perimeter. The fruits, the vegetables, right, the dairy, the meats. What's in the middle is processed. So I tell them to think about double dutch, jump rope, get in and out. Go where you need to go. Don't go down each aisle, because you'll end up with extra things that you had not intended, that are not, it's not going to be very healthy options for your child.
Yeah, and don't shop while you're hungry. You just pick a bunch of stuff you don't need.
Absolutely.
Dr. Buggs, we're up against a break. We're going to take a short break. Stay with us. We'll be right back.
Sometimes winning is simply a matter of not quitting. In the 85 years of the American Diabetes Association, we've had many wins, but we've never rested. Because 1 out of every 10 Americans has diabetes, and they rely on us every day, just like we rely on you. With you by our side, we can be there for more people and more families in their moment of need. Go to diabetes.org to join us in the fight to end diabetes.
Even the mighty might not see it coming. It's prediabetes, and it captures 1 in 3 adults. but you can escape. Take the 1-minute pre-diabetes risk test to know where you stand and prevent or delay type 2 diabetes. Be your own hero on smartphones everywhere at doihaveprediabetes.org.
Welcome back. We're here with Dr. Colleen Buggs-Saxton, pediatric endocrinologist and associate professor at Wayne State University School of Medicine. Dr. Buggs, we touched a little bit on the different types of diabetes. Explain the difference that we're seeing, especially the increase in type 2 in the pediatric population.
Okay. So type 2 diabetes develops when your body stops responding to insulin. So you have insulin resistance, and sometimes you can go on to the point where your body may need insulin. But typically, we can treat it with medications to help your body respond to insulin. So your body can make insulin, but may not respond to it. So that's type 2 diabetes. And with type 1, you know, that's when your body just completely stops making insulin. We do know with type 2 diabetes in children, there's more stress on the cells that make insulin, those beta cells. So those children can quickly
Burn out
and need insulin. Absolutely, yes.
We are progressing in terms of how we treat patients, and devices are becoming an integral part of what we do. Insulin pumps, continuous glucose monitors, which I love in the adult population, but you've been very successful in the pediatric age group with both, haven't you?
Yes, I have a wonderful team, and I love devices because they give us more information. They keep the child and that parent connected, so you can know what your child's blood sugar is, even when they're at school and you're at work. Also, it gives you more information, not just a number. It lets you know if your blood sugar is stable, if it's rising quickly, if it's falling. And you can only imagine when you're putting your child to bed at night, the comfort that you have knowing that the blood sugar is not dropping, and also that you get more rest, the child gets more rest. So these devices are wonderful, yes.
Are we experiencing a gap in care simply because people don't have access to the technology? A lot of times, for lots of different reasons now, whether it's insurance coverage or other things, we just seem to have that constant presentation of patients that can't get in line to get the insulin pump or can't even get continuous glucose monitors.
Yes. So unfortunately, there are policies that are made, and insurance companies have certain criteria that will allow an individual to get approved. So in type 2 diabetes, you will not get approved to use a continuous glucose monitor unless you're on insulin, which is counterintuitive because we want to prevent the disease from progressing to needing insulin. So it would be better if you had access to those tools when you're first diagnosed so you can implement changes to prevent your beta cells from burning out.
At least not so fast.
Absolutely,
right.
Yes,
Okay.
yes.
How successful are we in helping people understand that you can change your diet and not give up your culture?
It's still very challenging. There is a disconnect, and we need to do a better job because people enjoy eating. I don't want my patients to not enjoy food. And if you don't eat the foods that you enjoy and eat something else, you're likely to consume too many calories because you're going to eventually go back and have what you want. So I think we need to do definitely more work in this area to help people understand they can enjoy food, but maybe in smaller portions, and make some choices. I try not to tell people not to do something, but try to think and substitute. So if you're gonna have macaroni and cheese, maybe not have the roll along with that, or half of it, just eating less. People are open to making changes, but you have to present it in a way that can be fun, especially children. And I used to really encourage kids to eat more fruits and vegetables, but now I've changed a little bit and just tell them to put more color on their plates. So I had a patient actually take a picture of her lunch and had her mother send it to me to show me that she's actually trying to make some changes.
You know, we've always talked to people about diet and exercise. I think that the teenage group entering into, all of the pressures of society, the technology, they become a little different. The younger kids, we seem to be able to teach them a little bit better, especially if we have some persistence. The teenage group seems to be a little bit more rebellious in this whole discussion concerning dietary choices. You got any tricks up your sleeve to beat them into submission?
It's very challenging. I think it's also, we need to acknowledge, is very overwhelming. Just saw a patient recently, had to have a discussion that, you have type 2 diabetes. And I think it's frightening. It's frightening. You have to have a very supportive environment. I try to explain what is going on in their body and what my role is, to partner with them, and also what their role is in wanting to make changes. So I give them some options and just try to figure out where they are. What changes do they feel they can make? And also making sure that their caregiver, their parent, is supporting them through this process and that they're not by themselves.
So the obesity aspect of this is very concerning, simply because we know that the disease states can set in early and be lifelong and continuous. I can give you all the insulin in the world. If I don't teach you how to eat, I'm going to have a real challenging situation on my hand. And obesity right now is a sexy phrase in this society, especially with the advent of GLP-1s over the last 10 or 12 years. Where are you in terms of using those drugs in an obese pediatric population?
So I use them, and I have used them in several patients. The challenge now is the difficulty with getting insurance to approve it. So things have changed. The other thing is I share with families what these medications do, right? And they help your body to feel full, so it decreases your appetite. So I really want them to pay attention to the change in their dietary habits, because if there comes a point in time where they don't have access to the medication, they're just going to have to reduce the amount of food that they're eating. So these medications really work well in the majority of patients, but they do have to put some work in as well, making the dietary changes, exercising, and coming to appointments, and also paying attention to potential side effects so that we can investigate a little bit sooner to make sure that they don't have complications that can be associated with these medications.
So I had a patient the other day tell me, my blood sugar is always good. It's always around 200, okay? Which is a uneducated patient. A patient has been taught properly necessarily, but what targets in terms of blood sugar should we be shooting for in the pediatric age group?
When it comes to type 2 diabetes, we want to target to almost near normal blood sugars. So we want to keep the blood sugars like under 150, like after you eat a meal. That would be ideal. For people who are taking insulin 2 hours after you eat, we really want to target between 70 and 180, so 70 and 150 for type 2 diabetes. So in terms of, that's the goal, but helping patients to understand how their body may feel as the blood sugars are decreasing, so they may have symptoms of low blood sugar. So that may contribute to why some patients want to have a higher blood sugars, because it takes their body time to get used to lower blood sugars, yes.
Does the glycemic index for foods play a role in this? Because some of the patients, especially those that we have on continuous glucose monitors, can come in and tell us, if I eat certain things, I don't see my blood sugar rise significantly as opposed to other things, and I can actually see that spike to 160, 170 after that meal. Does that concept of glycemic index play a role in counseling these patients in terms of blood sugar levels?
Absolutely, and I feel it's a powerful tool to help motivate people to make those dietary changes, because they can see what happens when they eat certain foods, and it clicks, and they understand what we're saying. They can actually, the data is there.
Right.
And so I think it's a very powerful tool, and to allow people to have access to these tools before they need insulin can really have a major impact on health outcomes.
I try to liken it into driving. Okay, the continuous glucose monitor is like driving a car. You know when you're over the speed limit. Nobody has to tell you you're speeding, and that's exactly what it does to patients to help them understand how to make dietary choices and stay within the speed limit.
Absolutely.
Because if you don't, you're going to get a big ticket, have an accident, whatever.
I love it.
It may not be immediate,
Right.
but down the road, you're going to be seeing someone like me that says, we've got an issue here. It's your kidneys, it's your heart, it's your eyes, whatever. And circulation overall in people. Peripheral vascular disease has been linked to diabetes of long standing in this population forever, and it's just given us a lot of complications along the line. What's coming down the pike? Anything happening in the research arena that we can look forward to? Any new drugs, any new devices? I mean, where are we headed? You know, I saw a blurb the other day about pancreatic implants and all of that sort of stuff. What's coming down the pike that we can look forward to in terms of newer modalities for treatment of diabetes?
So when it comes to type 2 diabetes, I mean, we have these different medications, different drugs that are very helpful. And also, they also help with some of the complications that are associated, like heart disease, things like that. When it comes to type 1 diabetes, and I think that what we're learning from type 1 diabetes sometimes can be beneficial down the road to what may be available for individuals with type 2 diabetes. So we're putting more emphasis on identifying people early on who are at risk. And then we're also putting emphasis on, at the diagnosis, things that we can do, therapies we can offer to preserve the function of those insulin-producing cells. And then, as you said, is for those who have had the disease for many years, what can we do to replace those cells that are not working? So manufacturing cells that don't require, you know, as much immunosuppressive therapy and that have the ability to produce insulin. So there's a lot that's being invested in those different phases of individuals with diabetes, at risk for diabetes, or living with diabetes, to help improve outcomes.
That's outstanding. That is outstanding. Dr. Buggs, thank you so much for joining us today. We will do this again.
Thank you, thank you.
Our guest today has been Dr. Colleen Buggs-Saxton, Pediatric Endocrinologist and Associate Professor at Wayne State School of Medicine. Diabetes in our children is serious. As we've discussed, diabetes is no longer just an adult disease. The earlier it's recognized and treated in children, the better the outcome. For Primary Care, I'm Dr. Lonnie Joe.